Welcome to Peter and Phil's Courageous Conversations, a podcast addressing race relations and social issues in hopes that you'll be inspired to do the same. Now, let's begin our conversation with your hosts, Dr. Peter Weinstein and Dr. Philip Nelson.
I just want to take a minute to thank Nationwide for their support and continue to appreciate their support that they provide, not just for our podcast, but for the entire veterinary profession. And
welcome, Dr. Blackwell. Michael Blackwell is our guest today. Dr. Blackwell has made a lot of accomplishments and is one of the leaders of veterinary medicine. He served the Public Health Corps. He serves as the head of staff for the Surgeon General. He is a former dean of Tennessee College of Veterinary Medicine. And at the moment, he is executive director for a nonprofit that is spending a lot of time looking at access to veterinary care and is stirring up a lot of interest in veterinary medicine, and is also a popular speaker. And last but not least, he's a dear friend and a Tuskegee alum. So, Michael, I just want to welcome you to the conversation. And Peter, if you'd like to add anything, go right ahead.
Well, your inspiration is my perspiration. Dr. Blackwell, thank you for joining us. I appreciate it. I consider you a friend as well, and have enjoyed working with you in a variety of different capacities over the years. Probably don't know you as well as Phil, which scares me. I am so in awe of your bio. But I just want to thank you for joining us as well today and be nice to me.
Well, I want to thank both of you for the opportunity to have a conversation here today. I've known both of you for many years and admire you tremendously. Thank you for all you've been doing, because you are movers and shakers in this profession. And it's just nice to be with some kindred spirits here today. And I look forward to a challenging and courageous conversation.
So why don't we just get into it? Enough of the Mutual Admiration Society. Michael, why don't you let's start off by, why don't you tell us a little bit about your work in access to veterinary care, and how did this get started, and what made you write a grant in order to do something about this issue?
I euthanized a dog that was the constant companion of a veteran, a Vietnam veteran, so of our generation, pretty much. And this dog had been injured, treatable injury, but recurring theme of not having the money to pay for the care. For some reason, that case was different. It has stuck with me since it occurred. Now, mind you, I grew up in my dad's veterinary practice. So from a toddler on up, I was very accustomed to seeing euthanasias, perform a number myself. We all understand there are legitimate reasons to do that. But this one was different. And then as I started to think about that, I was horrified, quite frankly, saddened, felt guilt, because what was clear to me is that we are failing a portion of society. When putting a lens on that portion of society, we see people who work in service to others, our school teachers. We see our veterans. I mean, we see people who have significantly contributed to our well-being, and yet not ensured they have access to healthcare, in this case, veterinary care. So I knew I had a mission then. I'm on that mission because I know we can do better as a nation. And it's just been a wonderful work, not even a work, it's just a calling. But that was where it started. And what I came to appreciate is some of the structural challenges that we face. And I'll just start with one that I think is really, really important. Veterinary medicine does not operate as a system. We operate as a group of discrete sole proprietorships and increasingly corporations under the umbrella of being a profession, which is all accurate, but very little exchange of information, truly encouraging better understanding of the society we serve. And so the folks I've been characterizing are marginalized, and they cut across racial and ethnic categories. And one last thing I'll make about it, when you look at the economic trends in the nation, starting with the millennials and the fact they're projected to not make the income of their parents' generation, first generation of Americans who will not exceed the previous generation's income. And then look at our business model that's operating out there in the for-profit world. We're in trouble. We really are. And I believe we need to put on our big boy and girl pants, because we, up to this point, have been a self-governing profession, meaning we get to make up the rules of engagement, and we need to make up the rules that will enable us to better reach these underserved families.
So you said you're concerned about the business model, and you made the comment that we're in trouble because of the model. What is it about the business model endangers us?
The model is that of a cash basis industry. And when we had a thriving middle class with more and more discretionary money in their pockets, and healthcare was not quite as expensive, it's because of the cost of labor and equipment and supplies. That 20th century model worked back then, but today the cost of delivering those services have gone up. Veterinarians are not exploiting the public. It's just the cost of delivering business. And the idea that people can acquire adequate health care out of their pocket, well, let's just look at the human side now. Those prices are way beyond, they're in a different universe, but the principle holds. It's not, I don't think it's logical to think that the public, all of the public, can acquire healthcare through cash. And cash includes being able to acquire credit. And so when we look at our low-income families, many of whom work in service industries again, they're hit with high interest rates, which drive them deeper into debt. And the pet health insurance industry historically has not looked at households with income below 50,000. So these people are literally, these families are literally marginalized because our model says, no, you got to come in here and pay cash. Now, in contrast, I grew up in a practice where we carried in-house credit. Because back then, veterinarians, it seems to me, back then, veterinarians were more determined to ensure that they served everybody who came along. And that often meant carrying a debt. Most of those families paid their bills, but it was a lot of administrative investment to do in-house finance. And so I get the fact we evolved away from that, but we kind of like just wash our hands of it. It's the way it feels to me. And that meant we started to shut people out.
You're proposing a pretty provocative change here, or maybe return to a different model. I'm just trying to put some clothes on a skeleton you've created here in terms of understanding what you are actually proposing. If I could summarize what I think I heard you say, you're concerned about the model because it is a cash model, and you're concerned about the people who cannot afford the cost. And there have always been people who could not afford the cost. And you also mentioned human medicine and the problems that we're having with access to care there, and the problems we're having in financing our own health care. But you also say that veterinary medicine, the cost of veterinary medicine, the cost of delivering veterinary medicine has increased dramatically and almost prohibitively. So if the cost is truly onerous, who's going to pay for it?
It's a great question. It's the same folks who pay for human health care, pretty much. When we think of how we acquire human health care, there's a small category who just are rolling in the dough, and they can just go in and pay thousands, tens of thousands of dollars, hundreds of thousands, get that care. Most Americans acquire their health care through health insurance policies brought about through employment. And then for those who don't have that option, we have a different kind of insurance called Medicaid. Now understand, throughout all of what I just said, the individual needing the health care is not paying the full amount of that care. In the case of insurance, you may be paying 80%, 20% of those costs. In the case of Medicaid, the taxpayers. And then we ask ourselves, well, why do we want to do that? Why is it that the country built systems to ensure some level of health care with humans? It's because of public health. There's some pretty terrible microbes out there that could wipe out this country. Certainly, it becomes a national security concern when, so many in the workforce are sick repeatedly for different reasons. So we needed to have access, people to have access to care. Yeah, compassion was there, but it was more practical, safeguarding public health. Well, now what's happened is 70% of our households now are what we call bonded families. There are human and non-human members there. This is the evolution that we've seen with society going back over decades. And 65% of the infectious diseases, of course, that humans can get are zoonotic. And then when we actually add that mental, emotional health component, what I guess we're seeing then is the veterinary medicine service delivery model is, they still call it animal centric. I don't like to use that term for these individuals because they are family members, but it's animal centric. The VCPR, the smallest letter in that acronym is C. They just paid a bill and maybe administer meds at home, and yet the barriers to veterinary care are human related. And so if our model is not set up to adjust for the fact that we need an interprofessional approach, because the problems are with the humans. We know how to treat. We know how to change our treatment plan to go a long ways toward reaching the financial capabilities of our client. But at some point, there's not enough money in the room. And the threat to our nation by not coming up with a solution scares me, because COVID-19 is the current example of a zoonosis, and you see the impact it's had. There will be more. And with climate change, there are going to be ugly ones coming along. So we need the model to be operating as a One Health model, where there's literally, if the veterinarians are not doing certain things to attend to the needs of the human member of the family, somebody needs to be. And this is why we work with social workers and others, because the One Health approach is literally I believe, the only way we are going to have a safe future, better well-being. That's a
My
long
turn.
answer.
Michael, God, that you and the dean have put a lot of things on the table. The veterinary business model has existed in a doctor-centric fashion since Noah, who I consider to be the first veterinarian. And it has existed in a process that went from barter to cash to credit. And over the last 30 years or more, the cost of delivering veterinary care from a business standpoint has escalated in parallel with the expectations of consumers to be able to provide a level of care.
Yeah.
A report came out in January from Care Credit. It was their lifetime of care study that indicated 25% of pet owners were in a panic regarding the cost of care for a bill of $250. So it doesn't take a lot to make people uncomfortable with the cost of care. The economic business model in veterinary medicine is focused on profitability, which has been exacerbated by the corporatization, expecting high profitability to be able to have a product to sell, basically your practice. When your dad was in practice, when I worked in my first job, the business model, although the same pretty much as it is now, the overhead costs weren't as great. We didn't have nearly the inventory. We didn't have nearly the equipment. And so I think what has happened is, as the veterinary model has tried to emulate the human healthcare model and deliver a level of care that's comparable, we have made access to that care, whether it is in marginalized communities or even middle-class communities, even more challenging.
Yeah.
Now, you don't own a hospital at the moment. Phil doesn't own a hospital at the moment. I don't own a hospital at the moment. So we are actually consumers of veterinary care. And so I get to see the cost of care as a consumer.
Yeah.
My
shocking, right?
Yeah, I'd say, and my colleague who to whom I go for veterinary care is wonderful. I love him.
Yeah.
He worked for me. So I taught him all the bad habits that he has. He's gotten rid of most of those. But my belief in where you're headed came from actually working in the pet health insurance industry. So I worked, and Jack Stevens, who 40 years ago at the Southern California Veterinary Medical Association offices with Don Mahan launched pet health insurance with Lassie as the first patient or pet that was insured, and with Mayor Bradley in Los Angeles, I've seen that picture, launched pet health insurance with a desire to address what you started out with, economic euthanasia, putting pets to sleep because the cost of care has become a problem. Well, as the cost of care goes up, the access to pay for care flattens out or goes down. The issues that you're addressing with Align Care and your programs becomes more significant. And I think your position and your discussion is starting with one end of the bell-shaped curve, but I do think it extends almost to the top 90%, where the top 10% can afford veterinary care, but the other 90% are being taxed. And I've just spoken for a long time, but I do believe that we have to try to figure out how to adjust the business model at all levels. And it's not just bringing more money in, but how do we bring the cost of delivering veterinary care down to a more affordable level, so even middle class can afford the current cost of veterinary care.
Thank you for that, Peter. Dean, if it's okay, let me just,
No, go
I'm
right
actually
ahead.
still
Go right ahead.
answering your previous question. When I think of what you just described, I'm also thinking of what's wrong with our service delivery model. And that is this. Part of the reason those fees, that overhead is so high, is because operating as independent, discrete entities, we have increased the cost of care for the whole community. And what do I mean by that? Everybody's got a certain amount of equipment that they have to service through fees. If it's low use equipment, then other services, including the office visit, may be actually paying for that equipment. And so everybody in the community is subsidizing everybody else's x-ray machine. When I think of a system of delivery, we account for the fact that, we don't need every practice to be all things to all people who might show up. I mean, that's wonderful, but it's expensive. And that's part of what we're seeing here out of the 20th century is we never took that next step to become a system of healthcare. There are some fundamental structural problems, including the fact that we are still purporting to be the only ones that can touch the patient as a medical person. And sometimes it's a savior complex that I and only I can save this life. And Peter, you've probably heard me say this before, both of you. There are about 1 million physicians in the country, and we don't hear people, I have not met someone who thinks that 1 million physicians can take care of all the medical needs of 340 million citizens. Equivalently speaking, then we have about 65,000, I'm using round numbers, companion animal veterinarians, 40,000 or less outlets, practices, serving more than 200 million dogs and cats. The math is bad, is the way I like to put it. There are not enough of us to even reach all of society. And of course, COVID-19 exposed a tremendous deficit in how we're going about this, because now people are waiting months to go in to be seen, sometimes with a medical problem, not just wellness preventive care. What scares me is the public can literally go through a process with their legislature to create another source of medical care, licensing people that this happened in human health care, licensing other groups. The physicians made the mistake of not driving that process. Shame on us if we allow that to happen here with us. We need to remain a self-governing profession, but understand we're failing society, and society will seek other options if we don't get that addressed.
Peter probably put more sentences together in this conversation than he has in any of the past conversations, which reflects his passion about this subject. And so I'm going to take a little umbrage here and take the risk of stirring the pot a little bit between the two of you, because I'm interested in both of your views. But, I know all three of us. Oh, and by the way, Peter, I don't own a hospital, but I'm running one. And so I do understand the cost drivers in the business of veterinary healthcare. And I don't disagree with anything that Michael has posed or his analysis, except that I think it may be a little incomplete. And that's the problem with language. Having talked to Michael, I know he has a very in-depth understanding of where we are and the topic he's trying to address. And it's very difficult to counter or to present a complete picture. For instance, we all expected the cost of delivering healthcare to increase over time. We all expected that. But one of the drivers is not that we're taking, excuse me, I shouldn't say not. I don't think the impact of financing a radiology machine for every practice, although it could increase the efficiency if we look at it as a system. The fact that the radiology machines have advanced so much, and that your father didn't have an ultrasound machine because we didn't know how to use sound as a diagnostic tool. My point is that the advances in healthcare have truly translated into veterinary care. And those advances themselves are expensive, are more expensive than the original tactics and techniques that we used. Yep. And they're getting even more expensive because of inflation as well as further advances. Now, having said that, I want you to think about, what do you say to those people that say the human system sucks? I'm not sure we want to transform veterinary medicine to the human system. And if that's the case, you've created a dilemma for us who might believe that, because now you've convinced me that this system sucks, or the lack of a system sucks, but I don't want to move to another system that sucks. So do you have an alternative system? And before you answer that, either of you, I also want to challenge that because of these advances in human healthcare, I believe as a society, we now have a perverted view of life and death. And part of our ethos results in a transfer of wealth to the medical community, be it veterinary or human, because we have a questionable view about death and healthcare. And I actually think we have a more realistic view about the finite limitations of a biological life in veterinary medicine than we do in human medicine. Yeah. But I think that's changing. And I think that is a huge threat to the bonded family concept that you introduced here today. So I'd like to see the conversation cover those issues a little more in depth.
Well, the first thing I would say to someone who is concerned about trying to convert our system to operate like human healthcare, bad idea. I'm certainly not advocating for that. There are things we do that I think represent higher quality and more personalized healthcare. We don't put our patients on machines and maintain them for weeks and months on end when they're brain dead. I mean, there is a place for that medical procedure called euthanasia. It's an act of love, or certainly of mercy, embedded in our oath to relieve pain and suffering. We don't want to become like human healthcare when it comes to that, and a whole slew of other characteristics. However, I start at the system level, and if we go back enough decades, there were only physician offices. And there were these nurses in there, but they had no authority much to do anything. And through time, they became the first allied professional to work with physicians When the country was looking at the cost of healthcare, and I'm now going back to my days in Washington, the people who pay for healthcare needed measures, metrics. Who are the people? Human health insurance industry, government. I talked to people in government programs that were paying for the healthcare. And this lack of insight into the cost of care became problematic. And so systems got built in order to ensure those measures are made. And I usually like this example. For example, this doctor likes this particular branded drug, costs $100 a dose. She's used it for years, depends on it. A month ago, FDA approved a generic that costs $10 a dose. Do you think the people paying for healthcare is going to pay $100 per dose? So this is why we have to have that systems approach so that we start to figure out how to become more efficient and not duplicate, which was the other point I was making. And I would start with this one question, quite frankly, if I were talking about building an industry. On any given day in a general practice, when we think of 80% of what walks through the front door, what do we need to have in the back, under the roof, to take care of 80% of what's going to walk through that door? And what do we do about the 20%? Do we build on an extension and load it up with more equipment, which feeds the overhead? Or do we say, no, from a system standpoint, that secondary care is handled by this section, if you would, or part of the spectrum of care. And then for critical emergency care, even fewer. Because by doing that, 80% of the time, the consumers are not hit with a bill or a fee that involves being able to treat everything that ever came along. Now, I may be overstating that a bit, but that's the way the model looks to me today, service delivery model.
The service delivery model is broken. And it's broken because we have kept up with the technology of human healthcare, but we haven't kept up with the delivery model of human healthcare. And the savior complex is actually got our foot on the brake instead of our foot on the gas. I'm not suggesting we need to add another degree in terms of a mid-level practitioner. We just need to learn how to use the practice team that we already have.
Agreed.
And we need to learn what MDs have done well and not emulate what they've done poorly.
Right.
And we have to stop. In fact, you can go to an MD. If you need radiographs, they're not going to be done there. Neither is the lab work. But we've built, and rightfully so, based upon prior generational needs, we have built these healthcare centers. I mean, they are everything to everybody. They are the Mayo Clinic in 3,000 square feet.
Yeah. But and down the block is another one, and across the other zip code is another. And that whole community now is subsidizing all of that. Yeah.
And in a single doctor practice, when you're in the exam room, you're generating no income in the surgery suite, but you're charging the client to have a surgery suite. The same thing with your X-ray unit, the same thing with the lab equipment. And so the need to simplify and as a result, modify the business model so that, and I saw this in a group in Victoria, British Columbia, where there were 13 smaller standalone practices all feeding into a central hospital that shared the surgery suite, shared the radiology unit, shared the lab equipment, shared the hospitalization. They had high margins in their standalone practices, and they shared in the profitability of the central hospital.
Yeah, that's a system.
Exactly. And the thought being that, if we had the same income, but 50% net, we could charge less and still make more, which thus makes veterinary care more affordable on the wellness side of things, so that pet owners, when they have a sickness, might actually be able to afford it from that standpoint. So you're absolutely correct. We need to look at it from a system standpoint globally, but let's get down to the molecular level. We need to look at a system standpoint within the practice so that the team is involved with the delivery of healthcare and sharing responsibility, all staying within the Practice Act or a somewhat modified version of what the Practice Act may look like. But we don't leverage our team because it goes back to your savior complex. And I am sure that your dad was everything to everybody. And I'm sure you were everything to everybody. And I was everything to everybody until I realized the more my team did, the more I could focus on what I did best.
Mm-hmm. Mm-hmm.
And so, yeah, 80% of what we do, actually 20% of what we do generates 80% of our profits.
There you go. Yeah.
And so why bother? I hated surgery. If I'm building a hospital now, I'm getting rid of my surgery suite. So I fully agree with you. It's a convoluted way of doing things. We really have to think differently about the business models that we create and look at more of a collegial way of doing things as professionals instead of the independent business models, which are great to be competitive, but has been a part of what has driven costs up as well.
Unintentional,
Yeah.
consequence. Yeah.
It's no fun if I fully agree with the two of you, so I won't, just because I want to have I want to have fun. But I do want to point out that I don't think anybody can argue with the description of the inefficiencies that we have in veterinary healthcare. And these are not new concepts about learning how to use your staff and other paraprofessionals. But I do want to say we should give credit where credit is due, that I believe that practices are moving forward in that, particularly as new graduates come out and are being trained more and more, or at least enlightened to the challenge, efficiencies. But let's also realize that we're talking about different streams of improving or creating the system. In this discussion so far, we've talked about the cost of delivery, the drivers of the cost of delivery. We've talked about inflation. We've talked about team management, and all those are good things. But on the other hand, we're talking about that because of our desire to expand services, the delivery of services to 100% of our community, to make sure that the marginalized first have access to veterinary care, regardless of the cost or the need. Secondly, have access to effective care that might include the consideration of cost for the client that we're serving. And we've been softly targeting the marginalized population of our society. And secondly, understanding how we make medical decisions and provide medical options, including euthanasia. And when do we make that decision? And what you have said or inferred, Michael, is that it is unacceptable to make a decision to euthanize an animal solely for economic reasons. When an animal is a member of a family, you exclaimed woe and dismay because of the veteran who lost a friend. I'm assuming primarily for economic reasons, as opposed to our ability to correct the malady that this animal was suffering from.
Yeah.
And we've had discussions about euthanizing a family member that has been in the household for the present lifetime of a child, and the impact that has on that child, and that eventually that's going to happen, but it should happen when we truly run out of options, not because we've run out of money.
Yes.
Or at least if it is a partial economic decision, it should be a partial economic decision along with the medical economic decision. So I want to ask, who's responsible for health? And before you answer it, I want to offer the premise. I accept that we have no system. So the system can't be broken if we have none, right? We're delivering the healthcare through a capitalistic design that focuses on making money rather than delivering health. And if we designed a system that delivered health, we would incorporate all those efficiencies that you talk about. And I love the idea of adopting what works well in human healthcare.
Yeah.
I had a discussion with a professor about healthcare. Even when you have a third-party payer, who's responsible for the chronic smoker who now has COPD? Who should pay for that?
Yeah.
Who should pay for the pet that's been abused, or the pet that has been malnourished, not for any economic reasons, just given the wrong diet, if any diet.
Mm-hmm.
Do we teach health and hold individuals responsible for health as opposed to health care?
Well, let me start here. We don't really have a healthcare system for humans. We have a sick care system for humans. And it's because of capitalism that we have a sick care system. The sicker you are, the more chronically ill you are, the more money somebody's going to make. Turning on the TV, and every month, it seems, there's this new drug being pushed by the pharmaceutical industry about something we didn't even know existed in the universe now, like restless leg syndrome, which went away, by the way, after that money was made. I mean, the model there seems to be, if we can get you on a pill that you got to take for the rest of your life, then we hit a home run. So that's an example of what we don't want to replicate in veterinary medicine. I mean, that's where the insanity starts to really be obvious, how people are simply a vehicle by which people are making money and making it on their illness. So I forgot the other point I was going to make. I think when I look at our system, I believe we have a system. It's just a chaotic, disjointed system.
Sorry, I was saying we didn't. So,
well, I did, but I guess I should have stated it more accurately by saying the system we have is disjointed, and we need a unified system built on a One Health template. Going back to that euthanasia, a system that I think is more humane, frankly, is one that attends to that family at the time that euthanasia happens. It may be that most don't need some mental health support, emotional support, but some do. If that happens to be a senior who now is facing isolation and loneliness because the only companion now is deceased, then the cost of care, if you want to look at it from a financial side, goes up for that individual. More importantly, that individual will have poor health. And so a system would account for the fact that as a bonded family society, the role of these non-humans in these families actually are additive, add value. There are positive impacts of that. And a system that's intended to ensure that they are in the family and healthy is where I think the profession should go. I consider us in the business of family health care by focusing on non-human family members. And we're not talking about livestock here and so forth. We're talking about the human animal bond of the one where they say that's my family member that is on four legs or whatever.
So once Phil got done with his 6 or 7 minutes of monologue, I think there was a question in there.
And I'm sure I missed it.
Well, the question was, who's responsible for health? I mean,
right.
Oh yeah, I'd love to answer that
It took
question.
6 or 7 minutes to get to the question.
Everybody's responsible for health. It starts at the individual level. It goes to the family level, community level, the national level, international level, because microbes don't care about borders as a starting place. When we have food systems that are not accomplishing what needs to be accomplished so people are nourished, that's everybody's job, concern. Now, remember, I'm answering that from the standpoint of public health, which is my background, and in particular, infectious disease prevention and control. You know, I meet veterinarians. It's hard to find a veterinarian that really understands that the profession exists to ensure human health outcomes are good. We use old Yeller and rabies as a way to understand that at one point. But there are so many things that we're doing, starting with the food supply, but going on into the environment in general, and certainly that micro environment called the household. Our job is to ensure family health and well-being. Whether we like to say it that way or not, those are our roots. And so we are definitely responsible for health of the nation, is where I wanted to land. I'm talking about human health.
No, I totally agree. I say all the time, first of all, I have to say that you're the person that raised the veil for me in terms of the relationship of veterinary medicine and public health. I've come to the vision and position everything that a veterinarian does contributes to the public health, even deworming a dog.
Absolutely, that's high up there.
Contributes to the public health, and people don't think about that.
Yeah,
people don't think about the fact the only reason that dogs and cats are now in the house and not outside, relegated to outside, is because of our control of parasites and other vectors. And yet there are other prominent examples of how veterinary medicine has affected human health. I mean, I grew up in Mississippi, and at the time when I was a child, 1% of blindness in human beings was due to visceral larval migrations through the eye,
and that's increasing again.
I know, and because of hookworms in pigs and dogs, and because of the climate, Southern children ran around without shoes, either because they couldn't afford it or they just liked it. It didn't matter. They were exposed a lot more. When we began to control that in both food animals as well as pets, we dropped the percentage of blindness in the South.
Yeah.
And that occurred primarily through the veterinary arm of public health.
Let me jump in here.
I'm a strong advocate for One Health for that purpose.
Yeah. So when you
reason.
say they don't know that we are here to safeguard human health, meaning the public in general, is what you're referring to. Well, guess whose fault that is? We have done a poor job. In fact, I distinctly remember multiple conversations over my career talking about these public health concerns, just to have a colleague say, oh, if we talk about that, people won't want to have pets. And it's like, no, people are going to have pets. They love these relationships. They'd rather have a pet than you. I mean, kind of as a human. So we have, and when I used to go to the organized veterinary meetings, I can say this with all insight and honesty. I was relegated to second-class veterinarian because I wasn't there as some big practitioner who's treating the community. Yet I was making decisions during that time that affected the whole nation. And so we are even screwed up in how we value or what we value as important. So now we went through this phase where students all wanted to be specialists because somehow that got promoted as, well, real doctors wear these white coats and do this. And now we need to reverse that because we need more general practitioners, because 80% of what walks through the front door does not require specialists.
Okay, I sit here with you, two highly intelligent deans and former deans, as somebody with boots on the ground in the local community of a $34 billion industry. And I fully concur that we are a healthcare provider, but I really believe we have become part of a service industry. And that's where teaching has come up as a shortfall and a shortcoming. So, Phil, in answer to your question, who's responsible for teaching health, I believe, or something to that effect was your question. I can't remember that far back. It seems weeks ago. But
actually, it wasn't about teaching. It was who's responsible for health.
Who's responsible for health? I think that we are all responsible for health. I think there's a great overlay of parts of a Venn diagram. We're all responsible for health, but there's a couple of different levels of health. There's physical health and mental health. And I think we as veterinarians have to focus on two things. We need to focus on the physical health of the patient, and we've done a really poor job of educating consumers about their caring for a pet. It's amazing how many pet owners have no clue what they're getting themselves into when they adopt or purchase a pet. And then we are put in a position of educating them. And I'm not sure we do a very good job of that globally at the association levels nationally. I think we do very little at the association-wide statewide. And I would suggest that when it gets down to regionally, we do a lousy job, but it's now down to the responsibility of the individual practitioner to be the teacher. And we do a really poor job of that as well. We are transactional in many ways. This is what your pet needs, but we don't teach the why.
Yeah.
We teach the what, we talk the what, but we don't teach the why.
Yeah.
And then, we become advocates of the human animal bond. And so our goal is then subsequently to keep the pet alive and a part of the household because of the mental impact of the human animal bond of the pet in the household. And so we frequently leverage financially the human animal bond for cost of care. And so there are a lot of uncomfortable situations that are going on right now because of a lot of the things that I just said. But when it comes to health, I think we're all responsible. I think the human is responsible for the human health of themselves. I think the pet owner, guardian, parent, whatever terminology you want to use, is responsible at the same level that they're responsible for the health of their children. And we as an organization and as an association of veterinarians are responsible to educate the responsible person to take optimal care in A, preventing disease, and B, then treating disease with the comfort of the pet and the care of the pet and the longevity of the pet being the ultimate outcome. And so I think we have done a very poor job as a profession of letting the world know all of the different things that veterinarians can do. And during the past 2 years, we had a great opportunity, and I think Phil and you and I have talked about this on our podcast, either that or before and after. We did a very poor job of talking about One Health. We did a very poor job of talking about how this COVID virus was a zoonotic disease. And this was a great opportunity for the veterinary profession to take a lead and to self-advocate and be a cheerleader. We maybe have a savior complex in the hospital, but we have a lousy self-advocacy when it comes down to being a cheerleader for ourselves as a profession. And so the education model, the association model, the global model has failed us and failed our colleagues in giving the tools to help self-promote. And you know what? Once we tell people the great stuff we do, we don't have to sell ourselves anymore. But I still think we are responsible for teaching not just what, but why. And we haven't done that. I'm done.
So you made some very good points. It's very easy, however, to criticize based on the outcomes, the failures of a disjointed model, and to forget when you were in practice to that same picture through a disjointed effort because you were trying to get through the day. I have no problems with being part of the service industry. I grew up in food service. I see service as a higher calling. Characterizing the veterinary profession as one of the service industries is fine with me. It's what we're discussing, however, is how well are we doing it? And we keep coming back to a lack of a system, a lack of an intentional design that will result in addressing a more holistic delivery of medical services. And it's easy to sit here and talk about how we get paid for our services. We should get paid for our services. So there's going to be some transactional relationship as part of the system. What I'm hearing and what I'm coming to engage and to accept is that there's no forethought in the delivery of that care.
No, not outside the walls.
It's reactional. It's reactional rather than proactively trying to address. Dr. Blackwell keeps bringing back health outcomes.
Yeah.
And I'm not going to blame the vet schools for that. I will blame the educational system in general. I went to the dentist one time and he decided he's going to take my wisdom teeth. And when he made the decision, he said, and because of your age, because of your ethnicity, I'm not going to do this in the office. You're too valuable a person to society for me to take that kind of chance. So we're going to go to the hospital and we're going to put you under general anesthesia. Now, the words were very flattering, but I was more impacted by the fact that he looked at me as a human being. He understood my role in society. He may have inflated it, but still he made his decisions based on me as a human being, right? And he actually educated me about taking better care of myself. You mentioned as veterinarians, we don't get enough of a chance to advise our clients on which dogs they should get or the problems they're going to have with the breed they happen to select, or how they're going to prevent the predominant diseases by breed. But we don't do that to ourselves either. If there's a part of education that is almost missing, it's healthcare. And so when I asked the question about who's responsible for health, you're right, it is an integrated responsibility. And I'm all for any system that begins with individual responsibility. But you can't expect that individual responsibility if you're not educating people about that responsibility. And if you're not educating people on how to achieve health.
And at the end of the day, there will be people making decisions that negatively impact their health. And going back to the smoker with COPD, okay? And one might ask, and this kind of debate has come up during COVID, if somebody refuses to get the vaccine and now they want to go to the hospital because they're ill with COVID, should they be allowed to go at the front of the line? Should they bump the cancer patient out of the bed who's waiting, needs another treatment because they were irresponsible, some would say, in taking care of their health? We're going to always have that with us. But, we don't let that be a barrier to educating the public in general. We're schizophrenic, though. Let me tell you another example, and it comes out in subtle ways. Yeah, we'll beat the drum the loudest about the human-animal bond. I've seen it happen. You hear the band, and the veterinarians at the front of the band beating the drum the loudest, human-animal bond. But then, in the next breath, don't want to add value to that individual because it increases liability concerns or the size of the award because now it's beyond property. And so there's no getting around the fact that regardless of what the law says, the families see them as family members. And the law is already under threat to be changed by the American Bar Association's actions. I'm talking about now the most recent court-appointed representatives for pets in the court system. 2 states have passed such laws and about 3 others are in the process. So here's my starting point. This is what's most important. As doctors, we ask ourselves, well, what's wrong with the patient? Okay, I've taken a history, I've done an exam. What is it that I am seeing is wrong with the patient? And in this case, the patient is our society. Well, the problem is more than 1 out of 4 families, according to our national study, were not able to get access to veterinary care in the previous 2 years, overwhelmingly because they couldn't afford it. Now, that leaves us with 3 options. I like to keep it simple. We got 3 options with that picture because that is the literal picture that we're sitting with here today. One option is let's just ignore them. I mean, they're SOL. They shouldn't have gotten a pet anyway. We rationalize. It's not my problem. But oh boy, it is, because if we're not preventing and controlling infectious diseases in our communities are at risk. The nation is at risk. And that's not hyperbole. This comes from decades and even centuries of how infectious diseases have impacted societies. We can really start a process of just taking them away and passing laws that say you can't have a pet if your income drops below a certain level. Again, I don't think we're going to see that happen as a nation. So those individuals are in our communities, these non-human family members, with families that are among the working poor. And by the way, that is the largest cohort. It's not the indigent, it's not even the homeless that makes up the brunt of the population. It's the working poor, the ALICE group, asset limited, income constrained, employed people. And so they're there, they're going to be there. And it tells me that no matter what we do, that's not going to go away. In fact, it's going to get worse if we don't take that on. But it's not the veterinary profession's job solely to address that. We have a role with the medical care piece, but we need to advocate for systems that don't exist. We don't like to advocate. This will be a little provocative. While I was in Washington, I used to get really upset. Over the years, there were multiple issues that were at the table. And by the time I was leaving, it was antimicrobial resistance. Just to have the healthcare professions show up as a collective, talking about the medical issues, and they're right alongside the public health issues, just to have the veterinarians show up with pharma or ag. That is a well-trodden path in Washington. So we have put ourselves in this pickle in part because we have not advocated for systems of healthcare that would help us to serve the public. Giving veterinarians sole authority to put drugs in the food supply, it was veterinarians who were resisting that idea. No, let the lay people go down there to the co-op and buy whatever they want and put it in the food supply. In the food supply. And so organized veterinary medicine was the biggest problem there. I got a lot of scars trying to deal with AVMA and that whole governing process just to have us finally get there. But we had to go through a long, lengthy process of veterinary feed directives. And it's a policy-based thing, not a legislative thing. So I see us dropping the ball in a number of ways because we may be a bit myopic, or we're living in our own reality and not seeing that reality in the larger context. And it's just that simple change in perspective, Dean. You were talking about perspective last time we chat. Just changing our perspective about who we are, why we exist out here, why is it that what we do is absolutely critical to the health of the nation, and talk about it from the rooftop. I mean, celebrate that, because then the public takes care of the rest through the legislative process. We're allowing ignorance to prevail. That's where I'm wanting to land.
Thank you for joining us for another courageous conversation. Be sure to follow us and check back next week for more.